Milwaukee shoulder syndrome, MSS, is a rare and severe form of basic calcium phosphate BCP crystal deposition disease. It predominantly affects the shoulder joint and is characterized by large joint effusions, progressive joint destruction, and minimal pain despite the extensive damage. This condition is also sometimes referred to as appetite-associated destructive arthritis due to the involvement of BCP crystals like hydroxyapatite. 1. Pathophysiology. Crystal deposition, Milwaukee shoulder syndrome, results from the deposition of basic calcium phosphate (BCP) crystals, including hydroxyapatite and other forms of calcium phosphate, in the joint structures. These crystals can trigger an inflammatory response that leads to the release of proteolytic enzymes which degrade cartilage, tendons, and other joint tissues. Joint destruction. The combination of crystal deposition and enzyme release leads to significant damage to the joint structures, resulting in chronic synovitis and rapid joint destruction, particularly in the rotator cuff and the glenohumeral joint of the shoulder. 2. Risk factors. Age and gender. Milwaukee shoulder syndrome is most commonly seen in elderly women, typically over the age of 70. Joint trauma. A history of trauma or repetitive microtrauma to the shoulder joint may contribute to the development of MSS. Calcium metabolism disorders. Although less common, metabolic conditions that affect calcium and phosphate metabolism may also predispose individuals to BCP crystal deposition. 3. Clinical presentation. Joint effusion. The hallmark of Milwaukee shoulder syndrome is a large, non-inflammatory joint effusion, excess fluid in the joint. The shoulder joint often becomes visibly swollen due to the accumulation of fluid. Minimal pain. Unlike other forms of arthritis, MSS is notable for disproportionately mild pain compared to the severe joint damage observed. This can sometimes delay diagnosis, as the symptoms may not prompt immediate medical attention. Loss of function. Over time, the progressive destruction of the shoulder joint leads to significant loss of shoulder function, including weakness, limited range of motion, and eventual rotator cuff tears. Crepitus. Patients may experience crepitus, a grinding or cracking sound in the joint, due to the destruction of cartilage and the presence of loose fragments in the joint. 4. Diagnosis. Imaging. X-rays. Radiographs typically show severe joint destruction, including glenohumeral joint space narrowing, rotator cuff tears, and possible calcifications within the joint. Ultrasound and eye. These imaging modalities can detect joint effusions, synovial thickening, and rotator cuff pathology, including complete tears. CT or MRI may reveal large erosions and fragmentation of the humeral head and glenoid. Synovial fluid analysis. The joint fluid often appears hemorrhagic, bloody, or xanthochromic, yellowish. Microscopic examination reveals BCP crystals, which are difficult to visualize using regular light microscopy, but can be detected using specific staining techniques such as alizarin red. The absence of inflammatory cells in the fluid differentiates MSS from other inflammatory conditions like rheumatoid arthritis or septic arthritis. 5. Treatment. Non-surgical management. Joint aspiration. Repeated aspiration of the joint effusion can help alleviate symptoms and prevent further joint damage. Intra-articular steroids. Corticosteroid injections may reduce inflammation and joint effusion, though they are less effective in MSS than in other forms of arthritis. Physical therapy. Rehabilitation exercises can help maintain shoulder mobility and function, though this may be limited due to the extent of joint damage. Surgical management. Rotator cuff repair. In cases where the rotator cuff is severely damaged, surgical repair may be attempted, though the outcomes are often poor due to the extensive joint destruction. Shoulder arthroplasty. In advanced cases, joint replacement surgery, shoulder arthroplasty, may be necessary to restore function and alleviate symptoms. Debridement. In some cases, arthroscopic debridement, removal of damaged tissue, may be performed to reduce symptoms and improve joint function. 6. Prognosis. Progressive disease. Milwaukee shoulder syndrome is a progressive condition that leads to significant joint destruction over time. If left untreated, it can result in complete loss of shoulder function. Variable outcomes. The prognosis varies depending on the extent of joint damage at the time of diagnosis and the effectiveness of the chosen treatment. Even with treatment, many patients experience long-term disability. Prevention. Early detection. There is no specific way to prevent Milwaukee shoulder syndrome. However, early detection and treatment of BCP crystal deposition and shoulder joint effusions can slow the progression of the disease and improve outcomes. Minimizing trauma. Protecting the shoulder joint from repetitive microtrauma may reduce the risk of developing this condition, especially in older individuals at risk for BCP deposition. Milwaukee shoulder syndrome is a challenging condition to manage due to its rarity, the minimal pain it causes relative to the extensive joint damage, and the limited effectiveness of treatment options. Early recognition and intervention are crucial to preserving shoulder function and minimizing disability.
Can it occur with CBBD?
Yes, Milwaukee shoulder syndrome, MSS, can occur alongside calcium pyrophosphate dihydrate, CPPD, crystal deposition disease, although the two conditions are typically associated with different types of crystal deposition. Connection between MSS and CPPD. Co-occurrence. In some cases, patients with CPPD, pseudogout, can also develop Milwaukee shoulder syndrome. Both conditions involve crystal deposition in the joints, leading to inflammation and joint destruction, but the specific crystals differ. MSS is primarily associated with basic calcium phosphate BCP crystals, such as hydroxyapatite. CPPD, on the other hand, involves calcium pyrophosphate dihydrate CPD crystals. Elderly patients, particularly women who have CPPD, may also be at risk for developing BCP crystal deposition in their joints, which can lead to MSS. This overlap can complicate the diagnosis and management of these patients, as both crystal types contribute to joint damage and degeneration. Clinical significance. Differential diagnosis. In patients presenting with joint effusions and destruction, particularly in the shoulder, it's important to consider the possibility of both CPPD and MSS. Synovial fluid analysis may reveal the presence of both CPPD and BCP crystals. Joint destruction. Both conditions can lead to significant joint damage. Although MSS is known for its severe and rapid joint destruction, particularly in the shoulder with minimal pain. If a patient with CPPD also develops MSS, the joint destruction may be more extensive. Management, treatment approaches. The management of patients with both CPPD and MSS focuses on controlling inflammation, managing pain, and preventing further joint damage. This may involve joint aspiration to remove excess fluid, intra-articular corticosteroid injections to reduce inflammation, physical therapy to maintain joint function. In more advanced cases, surgical intervention may be required, such as joint replacement or debridement. In summary, while CPPD and Milwaukee shoulder syndrome are distinct conditions associated with different types of crystal deposition, they can co-occur, particularly in older individuals, leading to complex clinical presentations and significant joint damage. Early diagnosis and treatment are key to managing these conditions effectively.